Achilles tendinopathy. Obviously, there's going to be a fair bit of overlap, so we'll be able to roll through a little bit quicker. Just so everyone. A little man.
What's his name?
Clancy Jack.
Oh, no, this isn't fair. I can't like.
You can't compete with that.
What's your big boy's name?
Albie Victor.
Albion.
Albs and Clance. Yeah, so Clancy was a good boy last night. You know, he woke up twice. He's looking after his mum while dad is away.
Get on with it.
He does. Alrighty. So, patellar tendinopathy, jumper's knee. It's a classic tendon style pattern presentation. You're going to get all the usual things. So early days, it's going to be sore when you start to do stuff and warm up. As you get worse, it'll be sore, warm up, but not completely pain-free, and eventually it'll just be sore throughout exercise, preventing you exercising at all. Standard other side of the tendon coin is once you cool down, hurts like blazes. So this is that sort of delineation between is it sore when you're sitting or when you get up from sitting. So that can be one of the things. So patellar tendinopathy, it's not going to hurt while they're actually sitting down. Then they get up and holy crap, what has happened to my knee? Subtleties like that are probably the main differences we're going to see from the way they describe it. It's tender at the apex of the patella. So if we go back to talk about compression as being one of the things that tendons hate, if you think about the triangle that is the patella, the very apex of it is where all of that patellar tendon attaches. As you flex your knee, you're going to have the triangle of the tip of the patella pushing onto the tendon itself. You're going to get compression, guaranteed. It's a spot of susceptibility. Classic patellar tendinopathy is sore there. You do an ultrasound of it, there's a black hole underneath the tip of the patella. It's quite obvious and stark if you do have an opportunity to see one. I look at most ultrasounds and they're like, just a bunch of lines. Get my head around it. With the patellar tendinopathy one particularly, you can see the bone quite obviously. Nice and straight lines usually on the top layer, and then the undersurface of the tendon has got this black hole underneath it, so hypoechoicity they call it. And it's quite obvious in one that's quite well established. The main sports that they've done the research in are jumping sports, so jumpers, etc. So you're getting volleyballs and basketball. So all the research is essentially on these guys, but I think you can apply it to pretty much any sport that's dealing with patellar tendinopathy. So, as we've already said, tendinopathy, tendon side activity, it's a tendon breakdown. The equilibrium state that they were always in is disrupted. Usually because of a bit of thought. Biomechanics and the anatomy of the system are the other issues, and of course the movement itself, the way you're going through your activity. Risk factors have been shown in a bunch of epidemiological research to be increased weight, big BMI. So your ruckman in AFL, they do heaps of jumping and they're big roosters. Second rowers and number 8s in rugby, again, big boys, and they're the jumpers in the line-out, so they all the training and all that sort of stuff. So professional rugby clubs have jump counts, so they'll only let their guys jump a certain number of times. AFL's a little bit more slapdash about it because it's a 3-hour game and you don't know how many jumps the player's going to get in the game, so you need them to be very, very fit. And they have their tendons be fit. Other issues have been shown to be just volume of game exposure. So there's some cool research that they've done prospectively on a bunch of elite basketball kids. So teenage boys, checked them all out beforehand, did a whole bunch of tests on them, did ultrasounds, all that sort of thing, and then followed them for a couple of seasons. And court time as either training or game time directly correlated with risk of patellar tendinopathy. So it's just do too much without enough rest. What's weakness and poor flexibility? So the chain itself, if it is not functioning well, you're going to have to absorb the force more quickly. I talked about it a lot yesterday. It's the same amount of force when you land, they get spread out over 5 milliseconds or 1 millisecond. If you're stiff or if you're weak, the the time that it takes to land is shorter. So you get an increased force going through passive structures. Another cool prospective study on patellar tendinopathy, again with young volleyballers in this case, they looked at what happens at the hip, the trunk and the pelvis in a functional test. So they basically just did a stop jump. So kid had to jog up, stop and jump in the air. They looked at the range of motion of their trunk in that movement, and they found that the kids with an increased range, so poor control in that jumping task, had much higher rates of the changes on ultrasound that are the precursors to having symptomatic patellar tendinopathy. So there's a couple of sort of risk factors coming through now that are very changeable and that we can all affect. So differential diagnoses, infrapatellar fat pad pain. It often happens at the same time as a patellar tendinopathy. Your key distinctions for a fat pad are it's not just sore on the tendon, it's often just to either side of it. Passive hyperextension, or when they just stand there and straighten their knee, are two of the things that they can say, that hurts when I just lock my knee out straight. That's one of those, probably more fat paddy than it is patellar tendony. The fat pad, unlike the middle third of the meniscus, is super innervated, so it's extremely sensitive. So a little bit of inflammation in the fat pad can have a massive amount of pain referred from the knee. So we had a player at Lions who had a patellar tendinopathy that we rehabbed back, going well, but he hit a bit of a plateau, and tendon's going great, all the loading stuff's right, and every injury you get doesn't exactly follow what a textbook or the person standing in front of you at a lecture says. So it still looked like patellar tendinopathy, but it stopped responding to all the standard patellar tendon treatments. So we sent him for an ultrasound and it didn't show anything. So we'll keep treating. 4 or 5 weeks later, still no change. We sent him for an MRI and it just showed little bits of inflammation in the fat pad itself. Had an injection, cortisone injection to calm it down, because obviously in pro footy, A, there's a time limit, and B, they're still training all the time. So we're very jab happy, and I'm sure you guys are partially horrified on the inside. Oh my God, this cortisone and everything. But it's because they're doing so much exercise. So they're training 6 to 10 times a week with these injuries. So it's like, right, so they can be ready to go once the injury is resolved. Anyway, so got cortisone jab. 1 week later, playing. It was just like, the pain. Like this poor bugger had missed 6 weeks on the back of it just not being visible on ultrasound. So him not getting the jab the first time he went down, it often a difficult differentiation. Transferable pain syndrome, as we've rabbited on about already. Pain's more diffuse, hurts when you're sitting as opposed to when you're getting up from sitting, and isn't that particular point tenderness that you get. Osgood-Schlatter's. So we talked about severs yesterday. Osgood-Schlatter's is the classic traction apophysitis of your kid in year 9 and 10. So I was saying severs, year 7 and 8, 9 and 10, you've got Osgood-Schlatter's. This should be pretty obvious. It's at the tibial tuberosity as opposed to the apex of the patella. So it's the other end of the patellar tendon. Management, however, is relatively similar. So we're going to be talking about controlled unloading, not necessarily doing nothing, but just decreasing the amount of load they're doing. I reckon we're going to start to see research coming out about people doing isometric programs and all that sort of stuff, building kids back up that way. But kids in year 9 and 10, how much growth hormone can one human contain? So they do get better really quickly. It's certainly not a similar kind of sort of injury trajectory that you get with an adult having patellar tendinopathy. Again, harping on it, traction apophysitis, don't want to stretch them, so don't traction the apophysis. Cindy Larson-Johansson is the sort of less common cousin of Osgood-Schlatter's. It's at the polar patella, so that's one that looks exactly the same as the patellar tendinopathy. It's on the same spot, same sort of pattern of presentation, warms up, all that sort of stuff. It's really activity related, and that said, if it's a kid in the right hitting zone, probably lean towards it more likely being Cindy Larson's and treat it the way you would any other traction officers. So move on to management. So, obviously I'm going to be going on about isometric exercises and all that sort of stuff again, but first things first, you need to get a baseline. So these slow-moving, long-term injuries, you need to have somewhere that you've started from. This is a little bit more difficult in a patellar tendon because there isn't that Achilles, okay, put my foot out and it hurts. So you've got to find a thing that the person does every day that hurts and get them to rate their pain on that and say, okay, cool, whatever we did yesterday, do your thing and let us know how you're going. If it's worse, better, or the same. If it's the same or better, tick. If it's worse, you need to back off a little bit. But yeah, you need to find your barometer so that you can work out where to go from there. And then we go into our strengthening stuff again. So isometrics, start with wall sits, super easy. The depth is not as important to start with, just get them going with it. So you're looking for 5 minutes of isometric exercise a day. Start with bilaterals, they can go to unilaterals, all that sort of stuff. They can have weight on their lap. You can progress them along as they go. First things first, get them doing it. Get them to 90 if you can, but less of a drama. It's more just about get some load through the patellar tendon. Once they're going, you can look at your super slow concentric, eccentric contractions. So you can do that as a wall slide. It's not particularly comfortable. Just, I don't know, shirt rides up and all that sort of stuff. You can do it as a wall slide. Have a Swiss ball behind your back. That's a way to get it done. It's doable at home, but I don't find a lot of consistency with people that I throw this at. If they've got access to a gym, heaps better to go through the gym. So either a super slow leg press or Smith machine hack squat, as I've sort of got a picture of there. The feet are out in front of the body, so it's quite similar to a wall sit. The machine means you have to go further down with the weight, so a bum ends up well behind the feet, so it's essentially a gym machine directed wall sit. Stress the 4 seconds down, 4 seconds up. If they're in a gym, all of a sudden they've got other big behemoths sasasaring all over the place and all that sort of stuff. So they've got to stay under control. They've got to be nice and slow and controlled. You're still looking at a 5-minute load. Sorry, I didn't really stress that yesterday with the slow eccentric concentric. It's the same time frame as when you're doing an isometric. You're just replacing the isometric with a slightly, it's just an upgrading the activity. So if it's on an 8-second count, just do the maths. Work out how many reps they need to do in how many sets to get to 5-ish minutes possibly. Next step is department of walk. So you're doing your speed endurance element. That's going to be lunge walking, squat walking. At the Lions, we just get the boys walking backwards on an uphill treadmill. So they're doing that extension. So it's low load at a faster speed. So you're sort of dropping the load that they're actually taking, increasing the speed. So it's just a different way of stressing out the tendon. You need to get that fitness into the tendon as well as the strength. Then you go into low, medium, high cycle. So same as I was saying yesterday with the Achilles, you have your consistent, everyday, either isometrics or slow, controlled, concentric eccentric. You then have your medium day, which is isometrics plus your department of silly walks, and then your hard day is your isometrics plus a jumping program or a running program or whatever the exercise is that the person gets fired up by. And that program will obviously also be ramped up bit by bit as they cope. So as you're continually referring back to that baseline score, you just want to see it continually not get worse. And then you get back. I just thought this is a wicked picture. Then you get back to full function. It's bit by bit. So key thing to remember once people are going back into their function is tendons feel better once they've warmed up. So you've got to sort of drill into the person. It's not about how you feel at the end of the training session, it's how you feel the next day. It's not about, if you feel great at the end of the training session, don't keep going. You're not going to catch up. It's right off the stuff that you've missed. You're just going to have to start from here, stick with the program that you coach and we have sort of worked out with each other. Don't run on how you feel at the time. Guaranteed they'll ignore you for the first time. They'll come back, they're worse. You're like, righto, you just cost yourself a couple of weeks. Maybe next time you can listen. I could just say that. It's like, you know, it's not, you're not going to rupture off the bat this time. You've just cost yourself a few weeks. And usually they go, yeah, you can tell me that. Alrighty, so key management stuff for me is get your baseline, do your progressive strengthening stuff, and then your soft tissue work comes around it. So it's make sure your hips nice and strong, make sure that it's moving particularly well, make sure you've got good length in your quads without necessarily stretching them, make sure the knee joint, everything else around it's moving well. So apparently you've got to manipulate your ankle. All that sort of stuff to go along with.
If you don't have 10 centimetres of dorsiflexion, mate, you know what's going to happen.
That's right, the magic number. So, as I said, joint range and mobility up and down the chain. So if, as CJ said, decrease in dorsiflexion range means that you've got to absorb the shock somewhere else up the chain. So it is actually important despite the fact that Johnny cracks a lot over there.
Am I Johnny cracks a lot? Is
That's
that
right.
okay?
That's
Cool.
That's it. Alrighty, so adjunct. So the same old stuff as they said for the Achilles. Everything they've tested works really well on top of an exercise program. Your nitrous, your cortisone, bathing, as I said, no injections into it, bathe around it. PRP, sclerosing, all that sort of stuff. We've all talked about it as of yesterday. Anyone have any questions about the Patellar version tendinopathy control?
Yeah, I can probably get one done.
Yeah, do one.
I forgot to mention the current position statement of the American Association of Orthopedic Surgeons. Is that who it was?
Yeah.
When it comes to meniscus injuries, is that doing an operation for a meniscus.
For your for your degenerative one, not for a sport-related one. Sorry, that's the key thing. So for that,
For degenerative meniscal
medial
tear,
meniscal tear.
getting an operation is no worse.
At best, no worse.
At best, no worse than not getting an operation. That's the position statement of the American Association of Orthopedic Surgeons.
So basically, they've come out and said
This was before they heard about
Don't do it.
my summary.
this is prior to Johnny Cracksalot having a chat to them. It was that at best you're no worse if you have an operation than not having an operation. So basically, they're trying to say to their surgeons,
your best results.
don't do unnecessary knee operations. So it's a big burden on the health system, all that sort of stuff. That's where they've come from. So the research is pretty unequivocal.
Didn't hear about that at St George Hospital, right?
Yeah, we certainly did.
All right, so ITB, I think it's the easiest injury in the world to treat. I can't remember anyone not getting better with an ITB, and I've never